Good morning, and thank you to NCUK for asking me to participate in this important symposia. The topic of my talk is follow-up, and what does that mean for you? And within that, I'll also be including active surveillance. I'm Dr. Raj Srirajaskanthan, and I'm a gastroenterology consultant at King's College Hospital London and run the Neuroendocrine Tumour Service there. So in this talk, I'll cover the following areas. One will be about follow-up of NETs dependent on specific considerations in terms of grade and also site of primary, and then some kind of more specific guidelines that have been generated for different tumours arising from different primary sites. We'll then go on to discuss the role of active surveillance and possibly kind of future considerations. And within this, also resource considerations. So before I get into the bulk of the talk, I just wanted to focus quickly just on the two subtypes of neuroendocrine neoplasms. So we've been interchangeably using the terms NETs, NENs, and NECs, and I think it's important that we just characterize the different subtypes. So neuroendocrine neoplasms encompasses all types of neuroendocrine tumours and carcinomas. And these can be separated into two main groups, and this is based on how the tumours appear. So if they're well differentiated, they're called neuroendocrine tumours. And if they're poorly differentiated, which are often what we class as small cell or large cell type, they're classed as neuroendocrine carcinomas. So in this talk, I'll be primarily focusing on neuroendocrine tumours, without much discussion about surveillance for neuroendocrine carcinomas. So if we move on to the bronchial neuroendocrine tumours, this is a very busy slide, but what I was hoping to highlight from here is actually these are the ESMO guidelines, which is the European Society of Medical Oncology, and then there's also the following slide will be on the ENETS guidelines. And you'll see that there's some slight differences between them, but one of the kind of key take-home messages is that we have different imaging protocols for patients with bronchial with typical versus atypical bronchial neuroendocrine tumours. And so that's important. And then also these guidelines are primarily for patients who have resected disease. So if you've had a resected typical bronchial neuroendocrine tumour, you're looking at scans every 6 to 12 months, initially regularly for 3 years, and then extending out beyond that. And if you have metastatic disease, then again, the intervals for scans can be shorter, and then extended if the rate of disease is slow. So these are the ENETS guidelines, and again, there's a lot of information here, but basically, the kind of key messages are for the typical and atypical bronchial carcinoids, we should be having annual scans at least yearly, if not more frequently. And what they suggest is for the first 2 years that the scans are performed at a 3 to 6 monthly interval, and then annually for the typical. And then beyond those years, every 3 years, a scan with a CT and an annual chest X-ray. And they actually suggest this can be considered long-term, or lifelong. The role of SRS, which is somatostatin receptor scintigraphy, so either tectoid or ocular scan or PET, should be at 12 months, and then only again if there's suspicion of recurrence. For the atypical carcinoids, so these are different, slightly higher grade tumours, and so therefore have a higher risk of recurrence. Initial scan should be for 3 months post-surgery, and then they suggest a 6 monthly interval for 5 years. And again, as before, the somatostatin receptor imaging should be performed at year 1. After 5 years, they suggest an annual CT should be carried out, and again, this is felt to be indefinite. Moving on to the small bowel or pancreatic neuroendocrine tumours. So if you've had a curative resection, as in all visible disease has been removed, and it's a low-grade tumour, then ENET's recommendation is 6 monthly scans, and after a few years, this can be extended out to 1 to 2 years. There's a suggestion again that this should be lifelong. However, there are practical considerations here. And again, they've suggested for the grade 1 and low grade 2 tumours that you have either somatostatin receptor PET, so either a gallium dotatate PET, or if that's not available, take duodenal scan at year 1 and year 3 post-resection. For the higher grade 2 tumours and the grade 3 tumours, imaging should be on a 2 to 3 monthly basis. I think it's important to note that beyond 10 years, the risk of recurrence is uncommon, but not zero. And so that's when discussions could be made about the duration of follow-up beyond that point. The appendiceal nets, so the majority of these tumours can be curatively resected at appendicectomy, and a lot of them do not require follow-up. The cohort where we do consider follow-up are the patients that then proceed on to having something called a right hemicolectomy, where some of the colon is removed, and this is usually undertaken when there's a concern that there will be residual disease following the removal of the appendix. In these patients, if there's no residual disease seen, then follow-up is not necessarily required. However, there are certain risk factors which are subtle, for example, the grade or whether there were a small amount of lymph nodes involved, which may dictate follow-up. The guidelines are not really clear as to which cases should be followed up, nor do they dictate how long this should be undertaken for. And this will be a decision based by the clinical team when they review the histology plus associated risk factors. For the rectal neuroendocrine tumours, there's quite a large body of evidence from the different studies from around the world, and they've made quite a number of recommendations. So here, if you have a small, so sub 1 centimetre lesion, which is a low-grade tumour and is removed completely without any concern of residual disease, then there's no follow-up that's required. However, if there's a grade 2 or grade 3 tumour, then the recommendation is at least 5 years of follow-up. If you have an incomplete resection, then again, recommendation is for 5 years of follow-up with MRI and or sigmoidoscopy. And if it's over 10 millimeters, they recommend at least a 5-year follow-up period, with again consideration of PET scanning at 1 year. And for the grade 3 neuroendocrine tumours, again, slightly closer follow-up because the risk of recurrence is higher, and this will continue again for around 5 years. So I know there's a huge amount of different information for the different types here, but all of this is available to all the clinical teams managing these patients through the ENETS guidelines. And so, and some of these are very clear and helpful in terms of directing follow-up. For patients with metastatic disease, the approach is, again, slightly dependent on grade of tumour, clinical symptoms, and volume of disease. I think initially for the low-grade tumours, 6 monthly scans can be performed with either CT or MRI, and usually would perform some form of PET imaging, usually dotatate PET, or tectoid scan. If for higher grade tumours, so grade 2 or grade 3 tumours, then often we shorten that interval to 3 to 4 monthly, and we'd often consider PET imaging with both FDG and or dotatate at baseline. If patients are on therapy, such as somatostatin analogues, then we often consider 6 monthly scans, and if it's more other therapies like chemo or everolimus, then we're looking more towards 3 monthly. But this can be flexible and dependent on the clinical need as well. And for PRRT, again, the imaging and follow-up is very much personalized, dependent on the services and kind of which imaging modality they'd like to use. So active surveillance. So this is a term which is slightly sometimes difficult to understand. And basically, what we mean by that is that we choose a kind of proactive approach of monitoring rather than starting any therapy immediately. And this is well established in other cancers like renal cell carcinoma and prostate cancer. And it can be suitable for neuroendocrine tumors, especially for certain subtypes. It avoids need for unnecessary surgery and also medical therapy, which may not necessarily change the overall outcomes. So one common area where we undertake active surveillance are the gastric neuroendocrine tumors, commonly the type 1 gastric nets. So these are often multifocal lesions, and these are occurring because of the field change effect within the stomach. As a result, there's good recommendations and guidance that we only need to consider resection or removal endoscopically for lesions over 1 centimetre. So for patients with smaller lesions, these can just be surveyed endoscopically with a 1 to 2 year endoscopy, and that's being recommended by ENICS. Similarly, for the duodenal neuroendocrine tumours, the small lesions below 1 centimetre, a watch and wait strategy can be considered, especially if the tumours are not producing any hormones or causing any systemic problems like bleeding. For the larger lesions, then endoscopic resection or surgery could be considered, but because this can be high risk, it's quite reasonable to take an active surveillance approach. And for pancreatic neuroendocrine tumours, again, for the ones which aren't producing any hormones in patients who are asymptomatic, there's a good body of evidence suggesting that we can take an active surveillance approach for lesions under 2 centimetres. The ASPEN trial, which was a large global multi-centre trial, seems to suggest that a non-operative approach, i.e. observing these patients with regular scans and seeing if there's any change in size prior to considering surgery, can be taken and appears to be safe without there being any significant risk of developing metastatic disease. So what are the barriers sometimes to offering this approach of active surveillance? In part, it can be patient expectation. The idea of having a cancer that you leave in situ within yourself seems to be quite disconcerting. Two, that we often are saying that it's a kind of risk-benefit analysis, and therefore we'd say that the history is likely to suggest this behaviour, but obviously we can't guarantee that, cast iron nature, and so that can lead to a degree of anxiety. And also, sometimes there are some limitations in terms of the quality of the imaging, and there are no great biomarkers that we can use to assess for progression. So, and then there's just stress associated with just having regular scans, knowing something's in situ. And I think in part of it, some of this involves understanding the risk associated with surgery versus the likelihood of not needing that intervention. In terms of the neuroendocrine tumours arising from the small bowel and jejunum, ileum areas, so there was data about watch and wait using the PROMID and Coronet study. And I think on balance, there's been a gradual move away from using active surveillance routinely for patients with metastatic small bowel neuroendocrine tumours. However, for some patients with very small volume of disease or who have difficulty with tolerating analogues, then actually there may be some benefit in delay. But this is very much a discussion between the clinical team and with the patient to discuss this. So finally, I'd just like to run through some of the kind of practical considerations when we talk about imaging and follow-up. So I think one of the big areas with limited access is about PET imaging and somatostatin receptor PET imaging specifically. And we know that this has been an ongoing issue for at least 10 years now. And in a lot of places, there isn't any access to gallium data-based PET imaging. And so we're still using octreotide and tetroid scan. And I think that's quite adequate in a lot of cases, but sometimes it is worth consideration for the clinical team to look at referring onwards for gallium PET imaging. In terms of the frequency and duration of imaging, I think the frequency of imaging, again, is very much for a discussion. These are guidelines and guidance rather than kind of clear recommendations and set in stone. And so they're very flexible and fluid and can be in collaboration with the clinical team that are looking after you. The role of PET imaging is very interesting, and I think it does have a clear role in management of NET, and it can help change treatment and approaches to treatment. I think in our practice, we use it for all of the grade 3 tumours and a lot of the atypical bronchial neuroendocrine tumours, and also some of the grade 2 tumours as well. And it can help give further information when trying to consider treatment options. Ideally, we'd like to use kind of biomarkers and biochemical follow-up because then there'd be a reduced risk of radiation. And ideally, and at the moment, there isn't an adequate kind of biomarker test, whether it be the NET test or ctDNA type test that allows us to negate the use of imaging, but hopefully in the future, that may be something that comes into practice, and I think that would have a huge impact. I think as a patient, we have to, and also from a clinical perspective, we need to think about the associated risks of radiation regarding cross-sectional imaging. And if you're a young patient diagnosed in your 40s, you may be looking at, if we are considering lifetime follow-up, almost 40 to 60 CT scans during a lifetime, which is quite significant. And so therefore, I think discussion needs to be had about kind of the purpose of imaging as well. Also, radiation associated with that, and if you have concomitant conditions that also need imaging or other types of follow-up, then that can also add to further risks. I think one of the important points to highlight to patients is that just because you're having surveillance imaging like a CT or an MRI doesn't mean that you don't need to worry about kind of other national screening programs like breast, bowel, and cervical cancer, for example. So patients should be encouraged to participate in all the kind of national screening programs that are going on. And we know a lot of our NET patients do develop second cancers, and so therefore enrolling in those and participating is important. I think we should be aiming to incorporate quality of life assessment into routine care and follow-up. I think sometimes we focus too much on just what the imaging shows rather than specific symptoms, especially post-surgery. And I think incorporating those will lead to better quality of life, but also hopefully better patient experience as well. And then finally, the duration of follow-up. As I mentioned earlier, kind of ENETs, and as Mo have suggested, kind of lifelong follow-up for some of these tumours. And I suppose one of the questions that need to be asked is, if you're having a scan, how will the findings be influencing my management? And if it's not going to be changing what we do, then are the scans required? So what's the purpose of them? And also a time point between yourself and the clinical team when you feel that maybe you'd like to stop imaging because or scans. And I think that's a discussion that patients should feel free to have with their teams as well. So we've covered a huge amount in this talk, and hopefully if you have any questions, we can field those during the discussion. Thank you.